Now we get to move into physical factors that influence pulmonary ventilation. You can see the three here: airway resistance, alveolar surface tension, and lung compliance. This is where we're going to come back and talk about surfactant and what it does. Okay, so airway resistance. This one to me makes sense. If something is blocking your airway, you're not going to be able to breathe, right? So if you have anything that's constricting or obstructing your bronchioles, it can prevent pulmonary ventilation and gas exchange. So one example of that is this acute asthma attack, right? So if you have a quick onset where you have severe constriction of your bronchioles, that's going to increase your airway resistance, right? So you're not able to breathe freely. Remember epinephrine. We talked about how epinephrine speeds everything up, right? Heart rate, blood flow, but epinephrine also dilates your bronchioles. So this is good if you're trying to reduce airway resistance. You open those bronchioles up and now you have more pulmonary ventilation and more gas exchange. Here's where that surfactant comes in. So surface tension, it's the attraction of liquid molecules to one another at the gas-liquid interface. So the walls of the alveoli can be drawn together because there is water in the alveoli. So something that we probably don't think enough about here, what's the byproduct of cellular respiration? It's both CO2 and water, right? And when the CO2 gets to the lungs, we talked about in that video how the CO2 and the water go into the lungs. So maybe it also be good to think about the fact if you breathe on a mirror, you know how you fog up the mirror? That's due to the fact that there is some water, right? So this is not just gas, there is also some fluid there, some water in your alveoli. So what they're saying with this term surface tension is the alveoli form these nice little cup-like structures, right? What can happen is they can actually start sticking together. So if you have alveoli collapse like this here, if these alveoli are collapsing, they're not able to efficiently do gas exchange. So you want nice open alveoli, and surfactant is what stops this collapse of the alveoli. So surfactant is a detergent, it's a lipid and a protein. It's produced by the type 2 alveolar cells, and it helps reduce surface tension to discourage the alveoli from collapsing. This is something that we look at in infants, so I put this clinical note in here. If somebody's on bed rest, they might want to make sure that the lungs are fully developed before they initiate or start labor. So they'll look at the production of surfactant. So you can think that if a fetus is producing enough surfactant when they're born, their lungs shouldn't collapse and they should be able to breathe freely. There are some treatments if there is this infant respiratory distress syndrome. Remember, they're going from this nice, wonderful, warm environment with fluid and getting everything from mom, and now they're pushed into the real world, right? And they've got to be able to take that first breath. We talked about the APGAR score, right? So anyway, if they're not producing enough surfactant, their alveoli are collapsing, and then they're not going to be able to do pulmonary ventilation successfully and exchange oxygen and carbon dioxide. So we do have synthetic surfactant. We can spray that into the newborns' air passages to help alleviate some of that, alveolar collapse. Couldn't think of the word. So lung compliance is the final category here. So we talked about airway obstruction. We talked about surface tension, alveolar surface tension issues. The other thing that can happen is a change in the lung volume. So usually you see this if for some reason you've damaged your lungs and the elastic tissue isn't working as well. So basically your lungs aren't as spongy. They can't fill up as much, and then they can't exhale as much. So this could also be because of reduced surfactant And it can also be because as you get older, the flexibility decreases. I'm not sure if you remember in the skeletal system, we talked about how some of the costal cartilage at rib 1 and the sternum can start to fuse together. And so then you don't have that extra springy, or the ability to elevate your ribs and flare your rib cage out. Therefore, you can't take a deep enough breath. So what affects this total compliance of the respiratory system? If you have any issues with your thoracic cavity, right? If you have ossification, hardening of any of your costal cartilages, right? If you have any issues with your intercostal muscles, remember those are the muscles that are in between your ribs. All of those things can affect your ability to take in a full breath and exhale a full breath. The last couple things that I'm going to mention here with these respiratory volumes, I just want you to look at some of the terms and be familiar with them. So we talk about tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. So here on the next slide, you can see tidal volume is just if you're just breathing in and out, right? If I say take a deep breath in, that's your inspiratory reserve, and then I say exhale, that's your expiratory, and then we go back to our tidal volume. They want you to see that there's always a residual volume. You're never totally deflating your lungs and pushing every bit of air out. That doesn't happen. So we always have some dead space. There's some air that we breathe in that never contributes to gas exchange. So they call this dead space. They also want you to see that there are devices that we can use, pulmonary function tests, right? So if you may have seen this one here. I put this image in. If you've ever been hospitalized and had surgery after you come out of anesthesia, they want you to, move, right? Breathe in and breathe out. And they're measuring your ability to breathe in and breathe out effectively, right? So some of the things that we can look if you have an obstructive pulmonary disease, right? So if something is increasing your airway resistance, you're not going to be able to take as deep a breath or exhale as deep of a breath, something like bronchitis, right? You could also have some sort of functional lung issue. What if you have fibrosis of the lungs so they're not as spongy, right? What if you have TB, bacterial infection in your lungs? That's going to reduce the ability for you to inhale and exhale deeply. So this is another section that I've talked about on that summary 22 video. I like what I said there, so I'm not going to go over all of it again. I'm just going to talk about a few things real quick as we go through this. So when we do oxygen transport, we know that we carry oxygen on our red blood cells, right? Oxygen binds to hemoglobin. When we get to the tissue, we drop off oxygen. So the majority of our oxygen is bound to red blood cells. We have a little bit of oxygen that's dissolved in plasma. Carbon dioxide, right? So we drop off oxygen, that's for cellular respiration, and we pick up CO2, but we have many pathways to carry CO2. So we're going to go through those. I'll briefly go through them, but go watch that summary video. So oxygen transport, about 1.5% dissolved in plasma, about 98.5 is actually bound to that iron group of the hemoglobin. They'll talk about oxyhemoglobin, that's if oxygen is bound to the hemoglobin, and they'll talk about reduced hemoglobin, that's if you do not have oxygen bound to the hemoglobin. And what's in the oxygen's place? It's a hydrogen ion, right? So here we have a hemoglobin with a hydrogen ion, and then it comes in contact with oxygen at the lungs, right? And the oxygen displaces the hydrogen. Oops, not what I wanted. There we go. So this oxygen comes right in here and it displaces the hydrogen ion. So now you have the oxygen bound to the hemoglobin and you have this hydrogen ion floating around. When we get to the tissues, we want to unload, right? So this gets to the tissue, and we've got to separate them now. So now we want the oxygen to be able to diffuse. So the hydrogens are going to bind back to the hemoglobin, and we're going to drop the oxygen off at the tissues. This is a little complicated, but I wanted you to see just quickly how there are some regulatory mechanisms of oxygen. So whether oxygen gets dropped off or whether oxygen doesn't get dropped off in large quantities. So here you'll see that they have this P in front. This is partial oxygen. So if we're looking at the gases in your lungs, or we're looking at the gases in your muscles, we have a lot of different gases, right? We have oxygen, we have CO2, you might have some nitrogen. So they're looking at the oxygen that's mixed in with all these other gases. So that's what the P basically is just saying. It's partial oxygen. It's what part of your total gas volume is oxygen, is what they're trying to say. So here, if we have high partial oxygen, we have small changes in the hemoglobin oxygen saturation. If we have low partial oxygen, we have large changes in the hemoglobin oxygen saturation. Now, I know this sounds confusing. What they're saying is, if we have lots of oxygen, we don't drop off that much oxygen. If we have low oxygen in an area, guess what? We're going to drop off more oxygen. So they're saying that the binding of hemoglobin and oxygen, whether the oxygen comes off or not, is determined by the area amount of oxygen. So if you have low oxygen, that means you need it, right? If you have low oxygen, we're going to drop more oxygen off. If you have tissue with high oxygen, we're not going to drop that much oxygen off. So my question is, what happens if it stays bound, right? We want this to be a flexible system. We don't want to overload, right? If we don't need to drop off oxygen in one area, why would we do it? We move to the next area and drop off oxygen there if it's low. So again, they're trying to confuse you with this graph. They're talking about percent of oxygen saturation, and they're talking about the volume of the partial gas volume of oxygen here. So what they're saying is, we're talking about in the lungs. So they're showing you a picture in the lungs, And they're showing you what happens if you're at sea level versus what happens if you're at a high altitude. So what they're saying is the amount of oxygen saturated or bound to hemoglobin, whether you're at sea level or whether you're at a high altitude where there's less oxygen available, you still have a pretty decent amount of oxygen bound to hemoglobin. So in your lungs, oxygen is plentiful, right? Because you're breathing in. So we're not going to drop that much oxygen off at the lungs. That should kind of make sense. What are we trying to do? We're trying to take the oxygen in, right? So they're saying here, if you have lots of oxygen, you're not going to drop it off. You're going to have high saturation. How do you think this is going to change when we get to the muscles? So now we have muscles at rest and muscles at work. Do we see how we have lower oxygen? This muscle has 40% oxygen hemoglobin saturation. Why? Because it's dropping off as much oxygen as it can. So what they're saying is, if you have low oxygen levels, you're going to drop off more oxygen. You're going to have less oxygen bound to hemoglobin. These are some other factors that can affect how well oxygen stays bound to hemoglobin. So body temperature, right? If you increase your body temperature, you're using more oxygen, you're probably going to drop more oxygen off. Your blood pH will also depend on how well oxygen is bound to hemoglobin. The amount of carbon dioxide that you have. If your carbon dioxide is going up, if your carbon dioxide is elevated, that probably means you just did a lot of cellular respiration. So we're probably going to drop more oxygen off. This BPG, this is a byproduct of glycolysis or cellular respiration, the first step of cellular respiration, right? So higher levels cause a decrease in the hemoglobin oxygen saturation. So if any of these are high, you're going to have more CO2 unloading. So high temperature, high blood pH, high CO2, high intermediate of cellular respiration, meaning you're doing cellular respiration a lot, is going to cause more oxygen to be unloaded at the tissues where all of these are high. So it's kind of an interesting phenomenon that, you're dropping off the oxygen at the areas that you need it the most. So the oxygen and hemoglobin will disassociate or come apart more frequently if any of these factors are high. And then you can go through the slides if you'd like to. So here's our normal body temperature. If you increase the body temperature, the saturation drops. So you have more oxygen being dropped off. What happens if you get too cold? You have less oxygen being dropped off. So hypoxia, we've used this term before. Basically, if you're not getting enough oxygen to your tissues, and then there's all different kinds. If you remember, we went over these. There's anemic, meaning you don't have enough red blood cells. Ischemic, meaning there's some sort of impaired blood flow, right? We talked about carbon monoxide poisoning when we talked about blood as well. So I'll let you look at these. This term right here, sometimes people get these two terms confused. So hypoxia means inadequate oxygen, but hypoxemic means abnormal ventilation. So the CO2 transport here, this is the one that's confusing for people. There are 3 ways that we can transport CO2. So most of us would think that carbon dioxide is bound to hemoglobin, but it isn't, right? We know from that other video that about 70% of our carbon dioxide is transported as bicarbonate ions in the plasma. So oxygen transport, carbon dioxide transport, here's our 3 pathways. So carbon dioxide can be bound to hemoglobin, and it can form carbaminohemoglobin. That's the 20%. We also have 7% that is, or maybe it was 10%, dissolved in plasma. Yeah, 10, 20, 70. So this one is 20. This one is 10, where we just have CO2 dissolved in the plasma. And then these 2 pathways, the slow pathway and the fast pathway, make up about 70%. And we can see the CO2 and the water form carbonic acid, which then breaks down into bicarbonate and hydrogen ions. These bicarbonate and hydrogen ions are floating around in your blood plasma, and they are allowing for that buffer system, right? We are not going to talk about this chloride shift. There are other ways that you can transport negative molecules inside of your blood plasma. It can bind with hydrochloric acid, but we're not going to talk about these. So this is the equation that I want you to know. I want you to know carbon dioxide plus water yields carbonic acid, turns into hydrogen and bicarbonate ions. I want you to be able to tell me what's happening in each capillary system. So in the other slide I talked about, we move on to the alveolus, right? The other image was coming off of tissue. Now when we get to the alveoli, what do we want to do? We want to take in oxygen and we want to get rid of that carbon dioxide. And basically this equation just runs backwards. We call this the bicarbonate buffer system. The whole point of doing this bicarbonate buffer system is to be able to help the blood resist big swings or big changes in pH. So remember, your blood is supposed to be 735 to 745. Changes in the respiratory rate can also alter blood pH. So something that we're going to come back and talk about when we do acid-base balances is that if you have too much CO2 building up, it actually causes your blood to be acidic. So if you're not breathing out forcefully enough, if you're not exhaling forcefully enough to get rid of all of your CO2, the CO2 is going to build up in your bloodstream and it's going to cause your blood to be acidic. It's going to drop below 7.35. What's controlling the respiratory pathway? So I want to make sure we go back and remember our pons and our medulla. So hopefully we remember both the medulla oblongata and the pons have respiratory control centers. Yes, your brain's higher centers like your cerebral cortex can take over and control breathing, but where are kind of your set points, right? Those respiratory centers are located in your medulla and your pons. We'll come back and talk about hyperventilation and some of these terms when we do acid-base balance again, which will be in chapter 26. But hyperventilation, increased depth and rate of breathing that exceeds the body's need to remove CO2. So it's kind of the opposite of what we just talked about. We said if you're not taking deep enough breaths, if you're keeping too much CO2, right? So that would be hypoventilation if you're keeping too much CO2. What is this? Hyperventilation, right? You're blowing off large quantities of CO2. Well, if I told you if you keep too much CO2, your blood becomes acidic, what happens if you exhale too much CO2? Your blood becomes alkaline, right? So this can cause CO2 levels to decline. It can cause cerebral vasoconstriction, a cerebral blood flow issues, ischemia, right? Dizziness, fainting. Usually they tell you breathe into a paper bag because you'll breathe back in the CO2 that you're blowing off too frequently. Hypoventilation, decreased depth and rate of breathing that does not meet the body's need to remove CO2. So you're not blowing off enough CO2, therefore your CO2 levels are increasing, therefore your blood is becoming acidic. This can lead to respiratory arrest. So basically a period of cessation of breathing. Usually we're going to try to stimulate your respiratory rate. We could also put you on a ventilator. During exercise, we're going to have to adjust our breathing. Most of us know this, right? We're going to have a lack of oxygen in our muscles because we're doing aerobic respiration, right? So exercise can lead to anaerobic respiration and the formation of lactic acid. If you're not taking in enough oxygen, then the muscles are not going to be able to do cellular respiration and generate ATP. So you can see here that we do also have to adjust to high altitude, right? You have to acclimate yourself to the lower levels of oxygen. We talked about this when we did our blood chapter 17, right? Last couple of things you could look at are some of the lung diseases like COPD. Basically, you can either have an inflammation, right, of the bronchioles, or you can have emphysema where you actually have destroyed or done something to the alveoli. Basically, these decrease your ability to force in air in and out of the lungs, right? So this would be kind of that lung compliance issue. Most of the patients that have COPD are former smokers. They'll have labored breathing. They're not able to get a deep enough breath, so they're going to keep trying. They're going to have coughing and they're going to have pulmonary infections. Usually they're going to have respiratory failure due to the fact that they have respiratory acidosis. They aren't able to get rid of that excess carbon dioxide. And we said that can lead to respiratory arrest. So Emphysema is when you have permanent damage to the alveoli. There's something wrong with your alveoli and they're not able to exchange gas. And then you can also have an inflammation of the mucosal pathways. So it can be multifold. When we say COPD, it could be either one of these things. So COPD encompasses all of this. It could be you either have chronic bronchitis or you have emphysema. Asthma, we've talked about this a little bit. We know that we can have inflammation in our airways. If you have the airways inflamed, they can be thickened with the mucus, right? We're not able to get rid of it. We could also have an immune response. You might have heard the term cytokine storm, where you have all of these immune cells that just kind of rush to the lungs to try to help clear this, infection or whatever's causing the inflammation. And then that can obstruct your pulmonary ventilation as well. Tuberculosis, you can have bacteria. Basically, it loves to hang out in the lungs, right? So this bacteria is going to basically disrupt pulmonary ventilation because the bacteria are just dividing and dividing, and then you also have your immune response to this. We do have antibiotics that can treat and get rid of the tuberculosis bacteria. We also have lung cancer. I'm not going to get into great detail about these. I just wanted to show you that about 90% of all cases are the result of smoking. So this is why you'll hear a lot of people that teach anatomy and physiology, a lot of doctors and nurses, will stress the importance of not smoking. Usually by the time we find symptoms of lung cancer, usually that cancer has spread. So this is why lung cancer is really hard to treat. Cystic fibrosis, basically if you have an abnormal amount of mucus or really thick mucus that's being created by those mucosal membranes, it can clog passageways that would reduce that airway resistance, right? You can also have an abnormal gene that's going to block one of the channel proteins, and then that can lead to this viscous mucus. So at birth, respiratory centers are activated, the alveoli are going to inflate, and the lungs begin to function. It takes about 2 weeks before the lungs are fully inflated, and the respiratory rate's really high with newborns, and it slows down once we get into adulthood. The lungs are going to continue to mature. We're going to form more and more alveoli. So you're not born with the 300 million plus alveoli that you have. You're going to have more as you grow. And then respiratory efficiency decreases as you get older. Remember, we talked about the hardening or the ossification of the costal cartilage, and you have decreased elasticity in your lungs. At those connective tissues just don't hold up as well as we get older. So you're going to have that decreased lung compliance that's going to make it harder for you to breathe efficiently. All right, well, I think that's it, guys. Please go watch the summary video. It's a lot better. I just touched the highlights here on how we exchange oxygen and carbon dioxide. So go look at that summary video. Bye.